Hi class, and welcome to week 2 of Kin 353. Today we're going to be covering the foot, ankle, and lower leg. If you've read the two chapters on the foot, ankle, and the lower leg, then you'll notice that the first thing that they cover is the anatomy. And when we talk about the foot, you're mainly responsible for 26 bones, including all of the attachments for ligaments and tendons. For the purposes of this class, you don't have to memorize all of that anatomy, but I mean, some things to note here that I've put down as far as the bones go. It's important to understand, how each of the bones is named. It's pretty easy as it relates to the metatarsals and the phalanges, and then from there is just recognizing whether you're looking at the lateral side of the foot, which is where the cuboid would be, and if you're looking at the medial side of the foot, it's where the navicular bone would be. For the rest of the foot anatomy, your book covers these different sections of the foot, including arches of the foot, Achilles tendon, and plantar fascia, as well as joints and ligaments and muscles. And for this class, you will have to know some of the major structures, but nothing too much in detail as it pertains to the foot, like ligaments between the tarsal and metatarsal joints. Those you probably have to memorize more so for advanced classes, and if you ever got into like a foot specialty. A couple of things that I do want to point out is the medial longitudinal arch, just because we deal a lot with assessing athletes and how they can improve. And one of the things that's very noticeable in a person when they're standing barefoot is if they have a fallen arch or pes planus. And that a lot of it is due to this medial longitudinal arch. This arch gets its main support from the plantar calcaneonavicular ligament. And it also gets some help from the posterior tibialis muscle, and this kind of helps reinforce it. So when you're dealing with anything relating to the medial arch, those are the structures that you're mainly concerned about. The other part of this anatomy that's important is the tibial nerve and also the the dorsalis pedis artery. Those are palpable, or they're actually, you can test them. And for example, the dorsalis pedis artery is important when you have injuries to the lower leg or the foot. That's where you're going to be taking your pulse just to see if there's functional circulation to the lower extremity. This picture here I like because it shows you the anatomy the way you're going to be looking at it when you're assessing an athlete. So it's good to recognize all these structures on a person's ankle, because you're not going to have a figure in front of you when you're assessing someone. So you have to recognize what the medial malleolus and the lateral malleolus look like, the base of the fifth metatarsal, and understand where the arches are, and understand that, for the most part, a healthy, normal foot will look like this, and anything that's outside of this or out of the norm, you should be able to recognize it if something is out of place or if there's a major deformity. As it pertains to gait, or just that's a technical term for walking, you're not going to become an expert on the gait cycle and all the different dysfunctions, but it is important to understand the major properties of it. And as you can see here, there's two phases, the stance and the swing phase, and each of those is broken down into several other smaller phases. And the importance of that is when you see an injured athlete, you're going to notice that some of these steps are abbreviated, or some of these phases are abbreviated, or they're not taken at all. So you're going to see someone that's going to favor their non-injured side, or they're going to try to compensate in one way or another. Here's an article that I found on neuromuscular control and walking and just stepping on patients that were previously injured as compared to patients that were not injured, as far as ankle injuries. So what was interesting about this study was the authors measured kinematics, kinetics, and EMG, and all of that was described as neuromuscular control. And they studied this in patients with chronic ankle instability. They also had a group that had a previous ankle injury but did not have ankle instability, and they also tested a group that had never injured their ankles. So they measured these patients' tibialis anterior activity during a stepping motion, as if they were stepping down a stair. And they also measured the different angles that they would put their ankle at before, during, and after stepping down the step. So what they found was that the group that had previously injured their ankles but did not have ankle instability, and they called these patients copers, as in they could cope with having a previous ankle injury, was that they had more dorsiflexion during stepping down, and that they also had more tibialis anterior activity as compared to the group that had chronic instability, and as well as compared to the group that had never injured their ankles. So the authors found this important because they found that that position with maybe a more increased ankle dorsiflexion angle was more stable when weight bearing. So once they transferred all their weight to that ankle, if they had more ankle dorsiflexion, that would be a little bit safer for someone who had previously injured their ankle. And they found that someone with chronic ankle instability probably had not done enough rehab or had not learned that skill, which could be a problem and put them at more risk of continuing to sprain their ankle. So I'm going to post a PDF to this article so that you guys can read the full article and just kind of to understand the results of ankle injuries and any injury for that matter, but how certain people will recover from that and how certain people don't, and the importance of making sure that you rehabilitate those injuries correctly. So as for assessing the foot in athletic training programs and a lot of other sports medicine professions, HOPS, the acronym HOPS, is one of the ways that most injury evaluations occur, and it stands for history, observation, palpation, and special tests. And it's just a way to organize each injury evaluation regardless of the body part that you're working with. So in your book, you'll notice that there's a lot of general questions. There's specific questions that you'll be asking your patient in order to document a proper history. And I can tell you from experience and from doing, I would say, hundreds, if not more, of injury evaluations, the history portion of the evaluation is probably the most important part. And it will lead you to the diagnosis and the proper treatment for any injury, more so than any other part of the injury evaluation process. For the observation portion of your injury evaluation, it actually occurs throughout the whole injury evaluation process. If you're an athletic trainer or if you're in that field, a lot of the times you'll be able to observe the injury actually occur. So that actually benefits the athletic trainer a lot as compared to, let's say, an orthopedic specialist, a physician, a physical therapist. They're usually seeing the patient once the injury has already occurred, and they may only see them a few times, whereas the athletic trainer gets to see the injured athlete as the injury occurs, immediately after, and in the subsequent weeks as well. Palpation and special tests are important as well, but I can tell you from doing a lot of these evals, they're mainly used to rule out a lot of other pathologies as opposed to ruling in. I can also tell you that palpating a certain body part or a certain region of the body, you have to be very specific. You have to know your anatomy. You have to know what you're actually palpating and what you're palpating for. So you can't just randomly start feeling, over the skin or the bone. You want to know what you're palpating for and what normal is going to feel like. And that's why it's always important to do palpation and special tests bilaterally. You want to test the healthy side and compare it to the injured side. As for special tests, as it relates to the foot, long bone compression, tuning fork, Morton's test, and Tinel those are some of the major ones, and they discuss them a lot in your book. So as far as ruling out fractures, that's what long bone compression and tuning fork is for, and then the others are more neurological type of assessments. So let's take a look at some of these injuries. In the foot, anything can happen to it, especially if your patients, your athletes are playing sports. There's fractures, apophysitis, different types of bursitis that can happen in the foot, contusions, dislocations, and sprains. So here's some pictures of what these look like. And here we have apophysitis. So if you read in your book, this is very common in young athletes. It's similar to Osgood-Schlatters disease. It's basically the tendon pulling on the bone until it creates this damage in the bone. Then we have things like Jones fractures, avulsion fractures. These are called pump bumps, retrocalcaneal bursitis. And then we have things that are a little bit more serious, such as Lisfranc dislocations and fractures, which occur at the tarsal-metatarsal joint. And finally, we also have sprains, and in the foot, they are very debilitating. One very common one is called turf toe or great toe hyperextension. You hear a lot about this in the NFL or in football players because it debilitates a lot of these athletes for several weeks, where it's not a fracture, it's not a dislocation, but this sprain is so critical because anything where you have to push off of your feet, it requires toe extension, the great toe extension. And if it's painful every single time you put weight on it or push off of it, you're going to be very limited as how well you can sprint, how well you can jump, and even just land on your foot. Moving on to rehabilitation for the foot. And here is where I like to just help you recall the tissue healing process, where we talked about the inflammatory phase, the scarring phase, and the remodeling phase. And it's really important to understand that obviously the higher the severity of the injury, the more severe the symptoms are going to be, and the more severe, let's say, the inflammatory phases, and probably more scarring. And that all that you have to take into account when you're trying to rehabilitate. So that's why the first thing I noted here is non-weight bearing or partial weight bearing, and that has to do with the athletic trainer's decision to allow the athlete to continue to put weight on their foot or maybe completely take them off their feet. The reasoning behind this is based on the inflammatory phase. Remember that in the first 48 to 72 hours, your body is still bleeding internally, essentially, if we want to make this simple. So you're still getting a lot of swelling. Now, your foot is the lowest part of your body, so any swelling, any fluid is because of gravity is going to collect at the very bottom. And that means if you're allowing your athlete to walk, you're allowing more of that fluid to get down there. And that's why sometimes crutches or even having an athlete on a scooter may be a better option, at least in the first few days, if not first week. And once we've gone through that inflammatory phase after the first 2 to 4 days, that's when we can start recommending NSAIDs, non-steroidal anti-inflammatory drugs, such as ibuprofen and Motrin. And during this, the first few days, again, you may have the athlete non-weight bearing, so you're going to have them resting, icing, compressing, and elevating their foot. And kinesio tape is also a good option in trying to reduce a lot of that edema. There is a kinesio taping technique to do that. And the next phase would be to start increasing pain-free range of motion. You can do that with joint mobilizations and stretching. And in your book, it goes a little bit more into detail with that. And so just to kind of give you a heads up, this is essentially the order that you're going to do, that you're going to replicate for other body parts as well. You would start with decreasing pain and swelling, then increasing range of motion, next strengthening and neuromuscular control, proprioception, and finally getting back to play. I mentioned before, the severity of the injury is going to determine the length of this rehabilitation process, but it is always important to remember each of these steps, because there's going to be times where as a coach, as an athletic trainer, there's going to be different pressures on you for the athletes to return to play as soon as possible. And yeah, there is going to be some gray lines. You're not going to be as conservative every single time. There may be very minor injuries where the athlete, may also have some input and say that they want to play even though they're not fully healed. And that's fine as long as everyone's aware of the risks. Now, as it pertains to injuries such as major sprains, as in grade 2 or above, or athletes returning from surgery, that is going to, everyone's going to have to be on the same page as far as what will determine when they're ready to return to play, right? So that's why I put this word here, functional, as in, okay, they have full range of motion, minimal pain, they're about 80 to 90% as strong on the injured side as they are on the healthy side. Their balance, their proprioception is back to normal, or for the most part it is. But is it okay for them to return to play at that point? And so I like to do a lot of functional testing, as in in having them perform sport-related activities in a more controlled environment, and that way, as a clinician and then also the athlete can see if they're functionally ready, if they can, let's say if they play basketball, can they do a full sprint from one end of the court to the other? Can they fully land on their ankle? Things like that. And the coach should also be watching this so that they can see whether or not they can use that athlete with the amount of restrictions that they have. Now, moving on to the ankle and the lower leg, here's some of the anatomy that you're going to be responsible for. And again, it's there's going to be a lot more in your textbook, and if you do end up going through an athletic training program, you're definitely going to have to memorize all of these and be aware of the specific injuries that could occur to each of these structures. I can tell you that as it pertains to the ankle, these ligaments right here, you're going to have to deal with these a lot. The posterior talofibular ligament, the CFL, calcaneofibular ligament, the ATFL, anterior talofibular ligament, and then the tibiofibular ligaments, anterior and posterior, and then also the deltoid ligaments. Those are the major structures that you're concerned about when somebody rolls their ankle, or they get stepped on and roll over their ankle. These are the things that you're really concerned about. And as far as muscles go, it's really this way of remembering the different musculature that moves the ankle is a good way to memorize them: anterior, lateral, superficial, posterior, and deep posterior compartments. And there's a breakdown of that in your textbook as well. So moving on to the evaluation of the ankle and lower leg, I've skipped through the hops portion because we've already covered that, but just to give you an idea of what kind of special tests you would do for a lower leg and an ankle, and you can read the full detail on each of these, but percussion and compression is to rule out fractures to the tibia or the fibula. And you can actually do this on pretty much any long bone, as long as you're careful the way you're doing it. You don't want to cause any more pain than the athlete is already going through. And of course, you have the tuning fork test, which allows you to send vibrations down through the bone, and usually pain indicates that there's probably some disruption to the bone that you've just applied the tuning fork to. The Thompson test is a really easy test where you just squeeze the gastroc while the patient is laying on their stomach or in a prone position. And a normal Achilles will, once you squeeze the calf, the Achilles will then pull on the calcaneus, so you'll see the foot kind of move a little bit when you do that. However, if you have a Achilles tendon rupture, whether it be a complete rupture or a partial rupture, you could still get a positive. And in those cases, you will not see the ankle move or the foot move when you do this test. So that would indicate a positive test. And then these last three tests are for the ankle, the anterior drawer, talar tilt, and Kleiger's. And like I mentioned, here we note a test for each of the major ligaments that I mentioned in the previous slide, the ATFL, the CFL, and the deltoid ligament. And you can find all of these tests in your textbook. So the types of injuries that could occur to the ankle and lower leg are all the same ones that can happen to the foot, but we're dealing with a little bit different anatomy. So obviously, like I mentioned before, Achilles tendon strain or a complete rupture may occur. And here's a figure of what the Thompson test look like. Ankle sprains, you can either have inversion or eversion, and also what's called a high ankle sprain, which is when the athlete goes into eversion and dorsiflexion. And here's a little figure of how to differentiate which sprain you're dealing with, inversion or eversion. And injuries to the ankle probably going to look like this. Your athlete's going to have a lot of edema, ecchymosis, which is bruising, and you're not going to see very much of the tendons and the shape of the bones. All that's going to be filled up with fluid, so that's a good indicator of the severity of the injury. In rare cases, depending on the sport that you work with, you may also have to deal with dislocations, which is, in this case, it's an emergency. You need to make sure that you call EMS during these incidents, because there could be permanent damage if not handled correctly. And obviously this is something you never want to have to deal with, but you should, if you go through an athletic training program, you will learn how to deal with this in the proper way with a correct emergency action plan. And then fractures to the lower leg can include the tibia and the fibula, as well as the talus. But some of the ones that may not be as have the most notoriety, such as a stress fracture, can still be really important to deal with. And I mentioned stress fractures to the tibia because I think I mentioned it in the previous lecture. They can be confused with just shin splints, or the more correct term would be medial tibial stress syndrome. And it just, to the athlete, it just feels like they have shin splints. Like they get a lot of soreness, a lot of pain when they're running or jumping, whatever their activity is. And the only real way to diagnose it is with x-rays or with a bone scan. With the x-ray, you can't really diagnose it immediately though. This picture here, this radiograph, is probably 3 weeks after the actual stress fracture began. And the only reason you can tell is because the bone starts bulging out like this, because anytime there's a fracture, your body is going to want to heal it, so it sends a lot of osteoblasts to try to create more bone. And it does it so much so that it kind of overcompensates, so you start getting this bulge here. Moving on to rehabilitation, very similar to the rehabilitation in the foot slide. Just some of the things I wanted to address here though were when strengthening, for example, in the ankle, you're going to have to decide what type of exercises you want to do. And if you've taken like an exercise phys course or sports medicine course, you may have seen these terms: isometric, concentric, and eccentric. Those are all types of muscle actions. And depending on what exercise you want your athlete to do, isometric would probably be one of the most conservative or the most easiest, because you're not actually moving the joint. You're just kind of pushing against a stationary object. So that would be a very beginner type of exercise. Concentric is once you start moving through the actual range of motion, and the muscle is shortening. And eccentric would be if you are moving through a range of motion, but the muscle and tendon are lengthening. And they each have their place throughout the rehabilitation process. The other things to note are closed chain and open chain exercises, and those are usually implemented at different times. Uh, Anyone post-surgery, if you go to a physical therapist and you're going through a rehabilitation for, let's say, an ACL surgery, closed chain exercises are usually the first ones that they begin with, meaning your feet always stay on the ground and you move the rest of your body. So think of a squat. If you did a squat, you're moving your body, but your legs are staying on the ground. Whereas open chain exercises, the top portion of your body stays in one place, but you're moving your lower extremities. So think of a leg press or a leg extension. And finally, the last portion that we get to is bracing and taping. And there's a lot of, controversy as to, if you have weak ankles. When people say, I have weak ankles, should you use braces and taping? Because, if you think about it just in general terms, don't you want to strengthen your ankles? So by assisting them and using a brace or tape, you're kind of not letting them get stronger. And so my perspective on this is, I think there's a place and a time for everything. I think if you are, going through all of your joint mobilizations, your range of motion exercises, if your athlete is committed to a strengthening program that they're very compliant with, then there is a place to do ankle taping or bracing, because you're not just solely relying on that. You're doing all of the extra work as it pertains to rehabilitation. You're not just relying on one piece of, let's say, tape or a piece of plastic in an ankle brace. And part of that could be, psychological. Maybe the athlete feels a little bit more comfortable having some extra support. So just to kind of get you guys reading a little bit about this, I also will post this article on the authors that tested soft bracing and taping on two different groups, and they wanted to see what the results would be after 4 weeks of someone either taping or using a brace while doing activities after they had sprained an ankle. And according to this article, they kept testing the athletes or the patients even after the study was done. After the 4 weeks, they would still bring them back in and test them, and they did that for up to a year, and they found no differences in their symptoms. So they found that either soft bracing, so using like a sleeve or a soft ankle brace, provided similar support, and limited the amount of symptoms that these patients were having, as just as if they were getting taped. Tape seemed to do the same thing. And these are good articles to just keep handy, so that you can kind of, when you're making decisions, like, what should I do? Should I tape my athletes, or should I have them just wear braces? So if you're, according to this article, you're going to get pretty similar results. Now, why is that important? Well, let's say you're an athletic trainer at a high school that doesn't have a big budget. So it might be easier to just buy ankle braces, depending on what company you're buying from, because then you only have to provide an ankle brace to each of the athletes that has an ankle sprain, and they can wear it for the rest of the year, as opposed to, let's say, taping them every single day, and now you're wasting a lot more money on tape. So just some things to think about. So I hope you guys got a little practical information for foot, ankle, and lower leg injuries, and how to deal with them as well. And again, if you have any questions, please reach out to me, or post questions on the discussion board. Thanks, and have a great week.